Sorry. Thank you very much for all the talks, everyone. I've got a question for Professor Abraham. You were talking about how getting the courage and the moral courage and the bravery to override your seniors' advice, like the case where the pediatric resident overrode her senior about not taking out the tube of a child with incurable brain tumor. I think in our Asian sort of society where there's quite a lot of hierarchy, how do you think that's possible, for one? And how would you advise our junior doctors to take that brave step?
Just for a clarification, this neurosurgery resident is equal to the pediatric resident. Having said that, he certainly did not pull out the tube, but the decision to admit free of cost, he did discuss with his consultant on call. So that is what I feel. It's a set of core values which is developed over a period of time. It just doesn't come overnight. Throughout their training, this particular resident was in his 4th year of training, 2 years of diploma followed by 2 years of MD. So throughout the training, the team actually instills these core values, that these are the ways, it's not just the wisdom and the knowledge, you have to apply it to the situation. And there's always a senior to back up when they are juniors. So there is a consultant on call at all times, and depending on the head of the unit, whoever that is, we have the freedom to make decisions like this. The decision is, on one hand, it is the legality of supporting the treatment. On the other hand is the resources. So the first part is very clear as they go through their training, that we do need to give time for the parents, even in the most inoperable or untreatable conditions. That I think is something which we always insist upon, that we need to give time to the parents. Resources, of course, they need to check with their seniors. So the seniors should be available on call. And this is a system that we have over all these years, that there are different ties of people who are on call and are available 24 hours for a decision.
I had a question for Dominic, actually. Can I ask one? So I was interested in the facts values distinction and the flowchart that you put up. And I wondered, I'm increasingly concerned that what we used to see as a distinction between facts and values is becoming less and less so. There now seems to be a value judgment about which type of facts you accept. So things that we might see as facts or medical facts might not be accepted by others as facts. So I wondered if in Sumi's case around the natural therapy, the parents preferring the natural therapy, in your flowchart, would that count as a disagreement about facts or as a disagreement about values?
Well, I think, as I alluded, values do influence, and as you mentioned, which facts we choose. But I don't think we should be drawn towards this view that there are different facts at stake in this case. There is a set of facts, and then there's a question about what people believe. And in this case, the reasons that they don't believe the facts are partly related to their underlying beliefs, their values in natural therapies. And for that reason, getting more medical facts won't necessarily solve the problem. But I think we shouldn't. I think it's helpful and important to separate out these types of disagreements and not think that this is truly a factual disagreement.
So values go with beliefs?
Well, your values influence what you believe, but again, beliefs are different from facts.
I wanted to ask Professor Sarah regarding your last case where the parents apparently had left the child at the orphanage, but the team still considered the parents' decisions and what they would have wanted. What are the ethical obligations for the team to consider the parents if they are not taking care of the child?
So this was a hypothetical question. The child was already under the orphanage care, but in our practice, in our many years experience, at a critical juncture when you actually call the parents and counsel them that this prognosis is very bad, all those things, and most of the times parents never give up. So that was our premise with which we actually said the parents usually don't give up. We were not particularly referring to this child's parents. No. They had already handed over the child. So in similar situations, usually the parents don't give up. If the parents were here, they would not have given up. It's in a larger context, not particularly for this baby.
Any questions?
I'm Agni, I'm a neonatologist. I've got a comment and a question. The comment first. I was just thinking about Sumi's comment that in Singapore we don't see so many cases like UK and other parts. Why is that so? So perhaps I'm just wondering that our zone of parental discretion is probably very wide. And why is it wide? I'm thinking maybe we have got more epistemic humility. And why is that? Is that because we are really humble people, or do we have got everything right, or is something else? And perhaps it's because we don't have the teeth to, fight sometimes for the child's rights or advocacy, what UK or Australia or some other countries might do. So that was the comment. My second question is actually, I draw from our obstetric practices. So if there was an obstetric mishap and a child gets affected, if the parents don't decide to, sue the hospital or something like that, the child, upon turning an adult, can still sue the obstetrician. So taking that into context, suppose we kind of agree to traverse a course based on parental decision being within the zone of discretion, but later on the child grows up and decides, no, you didn't really act on my best interest, which have been possible, right? Do you ever foresee that thought that, yes, we might reach sometime there where, it wasn't right just to allow the parental zone of discretion to govern our decisions? It's a little complicated and forward-thinking question, but
Not at all. I thought it was a great question. Well, we have fewer cases in large measure because we're a much smaller country with a much smaller population, right? These other countries we're comparing many more people, so the chances of cases arising are more common. I think we're also not a very litigious country. Even our courts don't like cases to come to the court. They much prefer we adopt different modes like mediation or arbitration or something else, but not the court. So they're not keen on that. And if you read judgments, and most of you probably wouldn't want to, and some of them are extraordinarily long. Our judges have the habit of not just answering, which is what judges would normally do. They would answer the specific question and then, leave it at that, but not in Singapore. When we're asked a question, the judges tend to answer all related questions as well in an attempt to avoid more cases coming forward, so that they pre-answer the questions before they even come up, which is not common in most legal traditions. So in relation to your question about the zone of parental discretion, I don't know whether it's more to do with our family-centric culture, or perhaps it has to do with, I find, well, and as a Singaporean myself, we are a very pragmatic, practical people, really are. And I think this is some sort of understanding. Don't know, that's not always a good thing. It obviously can sometimes be problematic. And I do think the zone is quite wide in Singapore, and there is a lot of credence and weight given to what the family wants. And sometimes that means that the child, or the rights of the child, are not perhaps given as much weight as it should. Whether that's going to change, obviously if there is a case, it's going to change, isn't it? And the fact that you're mentioning it now probably indicates that there is some concern about the potential of that occurring. And of course, the length of your insurance for all practitioners must be quite tremendous. Oh, sorry, I'm doing that thing where I'm answering long question and then trying to minimize the number of questions. I'll stop now.
So you pointed to obstetric mishap and its influence. I mean, what I think we haven't mentioned it, but one of the really interesting and challenging cases is where there's an obstetric mishap, and then there are questions about continuing intensive care, and that hugely complicates, because in the equation here is, if this child dies and there was a fault, there's a small bill. If this child survives, there's going to be a massive bill. Now, that ought not to have any role, but it's often lurking under the surface. And people wonder, is that influencing the parent's decision in some way? Is it influencing the doctor's decision? Often particularly where there's our own faults have led to a child, our own guilt about what's happened then sometimes lead us to over-treatment. So sometimes those kind of mishaps influence decisions in ways that are very unfortunate. I find it very hard to imagine children being able to sue their parents for decisions that were made within what's thought to be a reasonable range of decisions for parents, even if it's subsequently suboptimal. So I can't quite imagine that ever being successful, but I might not be able to imagine that.
Can I just add as well, I think it points to the importance of clinical ethics case consult documentation. So you want your notes to be written up in such a way that the child, if they were to go back and access those, would understand the process that had been through to make that decision, and hopefully would be able to see the reasoning. So I think it's really important to think about, for anyone involved in clinical ethics consults, how are you writing up your notes, and how would the child in future read about that decision?
So this question is for Dominic. Follows on what Sumi said about giving a lot of weight to parents in Singapore. So I was just told about this case. I don't. So maybe somebody here knows the actual facts. But as I understand it, there were two parents who were doctors, and they had a young child. I don't think it was a newborn, but the young child developed this disorder where they stopped breathing when they went to sleep. So they were going to have to be ventilated while they were asleep. But they were otherwise completely normal IQ, normal everything. And the parents who were doctors wanted the child to die. And this went to the Clinical Ethics Committee, and they were very uncomfortable with this decision, but ultimately they supported it. So I'm wondering how your framework would apply to such a decision, and what you think ought to be done in this kind of case, because I found it quite a striking case in your experience.
I mean, I think when we're thinking about these decisions, I mentioned harm to the child, but the other significant component that we discussed yesterday is about the burden of treatment. And that's burden to the child and then also burden to the parents. So we were discussing yesterday about when that financial burden would fall on parents. So I think long-term ventilation is an incredibly burdensome treatment for both child and parents. And for that reason, usually in the UK, even in the context like Ondine's Kerr central hyperventilation, where the child's going to be cognitively normal, that would usually be thought to fall within the zone of parental discretion, but probably in this sort of situation be the sort of situation where you'd be strongly advocating, pushing and trying to support these parents to provide that rather than necessarily insisting it. But it's the sort of thing that I too would find very challenging to go along with parents who are not wanting that treatment.
After listening to Prof. Ross, your talk, the disagreement among professionals, so 1/3 of them. So sometimes in clinical practice, we have disagreements with the interprofessional groups, but they are self-reliant, like, if it's a gastroenterologist, depending on the ICU team, and they disagree, but you don't really want to go against them because you are dependent on the ICU intensivist for further treatment. And yet, a child is ventilated for a long period, and of course, parents will then listen to the facts from the ICU team rather than the other team. So how do you think how do you navigate through that when you feel one side is not really agreeing but do not want to go against somebody who's going to provide care for the rest of their patients?
Yeah, I think that in my view, these are the hardest clinical ethics case consults when there's differences of opinion amongst colleagues for exactly the reason that you've described. So there's a history and a future to those relationships that brings lots of ethical considerations to the table. I think that the guiding principle needs to be patient-centred care. So to the extent that people can, to set aside what's happened in the past with the previous patients or worries about what might happen in the future and think about, okay, this particular patient in front of us now. And in my experience, for most health professionals really share that as a key value. So being able to focus in on this specific patient is the way that I think those kinds of challenges should be approached. But that doesn't take away all the complex human messiness that comes with working in healthcare teams. So I don't have a great answer for you, I think, but I think patient-centred care as the moral compass is the starting point to try and have those discussions.
Just to flag, I think the most difficult cases of conflict are where there's personality disorders involved, and there are frank personality disorders. So, for example, the parents who are paranoid or who've got borderline personality disorder. It's very easy for me to kind of talk about in abstract the ethical issues and work out where the harm threshold is. But when you've got personality disorders, that becomes really, really difficult. And of course, sometimes the professionals have personality disorders, whether that's narcissistic personality disorders or, the full range. But we all know that there are one or two of our colleagues, or maybe two or three, who might fit into that spectrum. And then, of course, that then becomes really difficult. I think is outside the scope of conventional ethical analysis, though it causes lots of ethical problems.
Can I just add as well, have one more thought? I think that clinical ethics consults only work when everyone comes to the table with a kind of open heart, open mind, sense of goodwill, and the understanding that we've got an hour as a group to come to a resolution that everyone can live with. So if you don't have that starting point already, then I'm not sure that the clinical ethics space is necessarily going to be the space that's going to be able to resolve the issue.
Hi, my question is for Professor Dominic. You mentioned that the trust is actually the fulcrum between facts and values. So how do you actually build trust if the patient comes to you, presents to you clinically at a tertiary hospital, and this is the first time you're actually meeting him or her?
I think trust generally takes time, and it certainly takes time to build. It tends not to take much time to lose, and then takes about 10 times as much time to regain. It's the sort of simple mathematics of trust that I have in my head. And usually the key is to listen to the parent's story and to try and understand where they're coming from, to understand their values, why it is that they've come to believe the things that they have, and to try and take that time before jumping in with our own views to understand where it is that they've come from, the journey that they've undergone. And so, but I don't think there's a magic recipe, and sometimes it's very difficult particularly to regain trust that's lost.
Hi, I'm really just a question for Prof. Abraham. So, yeah.
Sorry.
So one of the worries is, and I'm going to ask you, to what extent is there a worry that people, when they stand up for what they believe in, right, risk becoming morally authoritarian, becoming morally pushy, right? It become just pushing people around. What's the risk there?
There is a high risk. So it's really good to have a team. It's like, the collective wisdom is what you're thinking about. Otherwise, I think there is a terminology in ethics called moral arrogance, where you really think that we think that we are always doing what is right. So it is good to have checks and balances in place and have a team to decide, rather than having only one person who's always saying what is to be done and what is not to be done. I think the only bottom line for us is, if there is an ED patient, as much as possible, as much as there are resources, provide. Beyond that, it's all case-based and decided by a team. So there is a very high risk of being wrong and having that feeling of moral authority. We need to have that checks and balances in place.
Julie.
No.
So Dominic and I came to an agreement today that the solution to our debate was, what we agreed was actually to more actively offer to parents the option of adoption or giving the child into care if they didn't want to resuscitate a 25-week-old. And so I wonder, in that sort of Ondine's curse case, why you wouldn't also think about that. And I wonder if you can talk about when removing a child into care should be, done instead of the child being allowed to die. So would you extend our agreed approach to other cases?
So a little bit like we mentioned yesterday, I think the boundaries, when we're trying to think about the boundaries of the zone of parental discretion, what we're often tempted to do is to think from the outside, from the inside out. We're trying to work out when are we crossing that harm threshold? Where's the harm threshold? But we can also try and think outside in. And when we think outside in, the question is, when and it's very much a function of society. When are we as a society prepared to pay for this treatment, or not pay for this treatment if it's treatment that parents are demanding? And when are we prepared as a society to take over the care of the child? So if we have ample adoption facilities, the ability to not only provide for the child, but provide a rich and fulfilling life for the child, a life that the child will value, that will determine to a degree where that boundary is, that upper boundary. But what we ought not to do is to have a situation where actually this child's care will be taken over, but there'll be nobody caring for this child. The child will just be stuck in hospital with no long-term caregivers, and actually the availability of adoption and foster parents for children with complex needs in the UK, let alone many of the countries that we've been discussing actively here, I think it is really very meagre. So the real worry is that these children will then be left to linger in systems that will then make their lives really awful.
Can I just add another spanner in the works, actually, because we know the case. And actually, there was a lot of moral distress amongst the medical staff, and the medical staff actually wanted to adopt the child. But the parents refused, because the parents' idea is not because of financial difficulty. I mean, they're obviously doctors and they're rich enough. Their objection was that the reason for their decision was because they feel that it's not the kind of life they want for their child. So it's more like a value kind of thing. It's not because of cost. So in that case, then, would you bring the case to court and force the parents to relinquish control?
So the kind of parallel case would be parents who think that Down syndrome is not a life worth living, and therefore they don't want surgery for the child and they don't want anybody else to adopt. And I think the consistent approach, consistent with the values of our society in the UK, would be to say, well, actually we don't agree with that. We're not willing to go along with that. We will take the child into care against your wishes. So that would be the approach, I think, in the UK. But other societies are going to take different decisions depending on, again, how much weight they're going to give to parents' choice about the child's quality of life.
I'm glad you mentioned the Ondine's case again. I was about to say a couple of things. One was about my earlier point about Singapore being a very practicable people. Think about the Ondine's case. One of the factors that made it very disturbing for those who were involved in it was that they struggled with the fact that the parents were both well off and were medically trained and were taking this decision. I think they would have struggled less, and Mayo and others can correct me if I'm wrong, would have struggled less if the parents were not well off and were struggling already, and this would make their life an even more intolerable, well, no, maybe not intolerable, but certainly a lot more suffering and struggling, not just for them, but also the child if they were to continue. So in that sense, that sort of practical aspect comes up. The other thing is, if this did go to court, right, so if the clinicians, for whatever reason, decided that, really want to pursue this, my suspicion, and of course I am just making a guess here, because of course we haven't had anything come to our court about something even remotely close to this, would be that they would err on the side of preservation of life. That would be my guess.
Just to go back to the question that was raised before about why does the UK have so many cases and other countries have no cases, one of the things that's interesting is that the cases encourage more cases. And that's partly because the courts develop jurisprudence, they develop an approach, and it becomes predictable. And it becomes predictable what the decision is going to be. So for example, taking some cases to the court is going to just not end in the way that you want it to end. So there's no point going to the court. Or in the UK, if you've got a situation where all the clinicians are agreed that this is harmful to the child, that the court will almost certainly line up with that. And although it might be long and painful, if you're convinced that it would be wrong for the child to go through with this treatment, that this actually may be the least unpleasant path forward, or the least harmful path forward. The other thing, just to allude to it, this discussion of parents' motivations and their views, one of the things within the zone of parental discretion that sometimes comes in is this concern with complicity with what are seen to be suspect norms. So if the parents have, for example, got views about disability with which the clinicians don't agree, or they've got norms in relation to a female child with which the clinicians don't agree, but it's within the zone of parental discretion, so we ought to allow these parents to, for example, withhold treatment from a 24-week female infant, but there's concern that actually they would make a different decision for a male infant, then that also can generate moral distress. And sometimes it's useful just to clarify that that's what's going on here, that it's worry about complicity with something that the health professionals don't agree with. But then the zone of parental discretion becomes a really useful framework for thinking about that we can step back and say, actually, we might not agree with this parent's ways of thinking, but this is the type of decision that we would allow other parents to make. If it wouldn't be significantly harmful to the child, or if this would be sufficiently burdensome treatment that we ought to allow parents to make it, then perhaps we ought to not take this moral burden on ourselves and say this is a decision they're permitted to make.
So Dominic, I can imagine a case where you're talking about gender differences. If you had two babies, let's say they were twins, one boy and one girl, and they wanted to, allow the female child to pass away, but do everything for the male child, that I would think that's very problematic on so many levels. How would you respond to that?
I mean, again, I think it's useful to think about what are the ethical boundaries of decisions? When do we allow parents to make suboptimal decisions? And when do we try and advocate for the interests of the child? So within the zone of parental discretion, we ought to, as clinicians, be advocating for the child in front of us. But we ought to also be respecting parents' wishes within the bounds of this. So I think that in the type of case that you describe, it sounds extremely challenging, but if this is the type of decision that we ought to respect for parents, then that might be the ultimate answer.
I know, I take that to court, actually. I would.
If we disagree, right, or we don't go with whatever is, I mean, we can say no. I think we can say yes. And I agree, collective is always better. Consensus is always. And I'm sitting on just a reflection, sitting on the CEC committee, that many a times I may have been one of the only one or two people that was on the other side of the consensus, right? And thinking about it and looking through what every individual came up with. And I agree, I said, I concede. It's a consensus I agree with. I may not agree with exactly what it is, but as long as it does not actually hurt my own sort of point of view or value system, and I don't blame you for saying you said this and then I say no and then that's what this happens. I think as an adult who can think and can rationalize and have that capacity, we should have that, I suppose, kindness to also allow individuals to say no, I disagree.
Rose, what would you do with the male-female primitive case?
Yeah, I'm really worried about this one. Because it does seem like a case where first of all, just we'll do the philosophy thing and just assume that the two are exactly the same in all regards except for their sex.
Well, the male probably has a worse prognosis by virtue of being male. To be completely frank. No, seriously, statistically, they have a worse chance.
Right. So there you go. Maybe that gets us out of it. The clinical situation will never be exactly the same.
The male one alive. So they're going to pay.
It's very, yeah. I think it's really hard because it sounds like a case where if you're going to take seriously the part of the zone of parental discretion idea that parents' reasons are not, the harm to the child is the big thing and parents' reasons fade into the background, this type of case makes it sound like you need to let parents have that choice. But I think reading the room, there's a pretty strong moral intuition that we shouldn't. So to me, this is a time when reflective equilibrium comes into play. If we've got a conceptual construct and a set of intuitions and the conceptual construct doesn't align with a very strong shared moral intuition, then it might be time to tweak the conceptual construct. So, my strong intuition is that you should not let them choose just on the basis of gender.
Okay, with that, we'll come to the end of this really interesting session.